Hey guys, Nick here. Welcome back to Renal Physiology. Now this is where the bulk of the material from the renal chapter will come from, just because so much is known about kidney function. It's very clinically relevant and very well tested on board exams. So lots of high-yield stuff coming up in these slides. Let's buckle up and get to it. Let's first start off with the big picture, looking at the body's fluid compartments. The entire body is made up of two things: non-water mass, which accounts for about 40% of the total body weight, and water, which accounts for about 60% of the total body weight. Recall that the body's total water is split into several compartments. An easy way to remember this ratio is the 60-40-20 rule. This rule describes how water is spread out throughout the body. The 60 comes from the fact that 60% of the total body weight is water. Two-thirds of that total body water is inside the cells, or the ICF, and this is where the 40% comes from. The ECF, or the water outside the cells, makes up 20% of the entire body's weight. The ECF, or the water outside the cells, makes up 20% of the body's entire weight, which is also 1/3 of the total body water. So this is where the 20 comes from. So, the 60-40-20 rule means that 60% of the total body weight is water. 40% of the total body weight is water inside the cells, or the ICF, and 20% of the total body weight is water outside of the cells, or the ECF. The volume of the ECF can be measured by inulin. Inulin can move out of the vasculature but is not taken up by the cells, so therefore inulin remains in the ECF fluid. The ECF can further be divided into two compartments, the plasma and the interstitial fluid. It's intuitive that the interstitial volume will be bigger because that's the volume around all of your cells, whereas the plasma volume is only the volume of fluid inside the vascular system. Plasma volume is measured by radiolabeled albumin. Albumin is used to measure plasma because it's too large to pass through the fenestrations of the capillaries. Albumin also plays a role in establishing the plasma oncotic pressure. Do you remember what this is? Correct. It's the pressure created by the proteins, notably albumin, that pulls water into the vasculature. As we mentioned, albumin is too big to pass through the capillary fenestrations, so we should never see it in the urine. However, generally speaking, what do we call the condition associated with significant proteinuria? Well, that's nephrotic syndrome. These patients will present with protein in the urine and a decreased plasma oncotic pressure, because all that albumin is being lost from the plasma. We'll talk about this a whole lot more when we get to the renal pathology section. Now, before we get into the differences between these compartments, let's walk through a sample problem together. How is the body water of a 70-kilogram man divided? Well, if he's 70 kilograms, 60% of that will be water, which makes up about 42 liters. 2/3 of that water is the ICF, or the water inside the cells. The remaining 1/3 is about 14 liters, the water outside the cells. Of that ECF, about 1/4, or 3.5 liters, is in the plasma. The remaining 3/4, or about 10.5 liters, is in the interstitial space. Be sure to keep in mind the 60-40-20 rule of body water distributions. These calculations will flow a lot easier come test day. Now let's talk about what these fluid compartments are actually made up of. The major cation in the ICF is potassium, while in the ECF it's mainly sodium. One of my college professors said that a cell is like a banana in the open sea. Think of all that potassium surrounded by salt water, and you'll never forget the major cations of these fluid compartments. Now these two cations have established concentration gradients that encourage movement from a high to a low concentration, depending on the channels that they Now these two cations have established concentration gradients that encourage movement from a high to a low concentration, depending on the status of the channels that they travel through. For example, in a cardiac myocyte, rapid depolarization of these cell membranes happens when a voltage-gated sodium channel opens and sodium rushes into the cell. Eventually, this depolarization will cause myocyte contraction and relaxation, which will lead to repolarization once voltage-gated potassium channels open and let all the potassium out of the cell. Now this interaction of cations flowing down their concentration gradients will be discussed in much greater detail in the cardio chapter, but it's a great example of the relationship that the ICF and the ECF share with each other. Now the ICF and the ECF also have different anions. In the ICF, it's mostly protein and organic phosphates. Remember that the majority of the body's proteins and ATP are inside the cells. As we all learned from our Bio 101 classes, the cell is the most basic unit of life. The cell makes things happen, and it needs all those proteins and ATP in there to do so. In the ECF, the major anions are chloride and bicarb. Remember that the bicarb is used as an extracellular buffer system as well as a means to transport carbon dioxide. Now quickly, can you remember the other two ways CO2 is transported in the blood? Correct. Bound to hemoglobin and dissolved in plasma. However, the bicarb route of transportation makes up about 90% of the total CO2 transport. The osmolarity of both compartments is about the same at about 290 milliosmoles, which means there's no net movement of water in or out of cells at rest. Let's try another practice problem. What is the 60-40-20 rule of the body water compartments? The 60-40-20 rule means that 60% of the total body weight is water, 40% of the total body weight is water inside the cells, and 20% of the total body weight is water outside the cells. For your test, it's important to remember the various substances that can serve as surrogates for different fluid compartments. For example, inulin will often be used on the test as a reference for which compartment. Correct, the ECF. It's also useful to just have a general idea of the volume of each compartment for an average human being, because if your calculations come out to be really messed up and you get 30 liters of plasma volume, you'll know right away you did something wrong and you can go back and check. Now, let's move on to the actual functions of the kidney, starting with filtration. The glomerulus is a very delicate, three-layer structure that acts as a filter for plasma. Its layers consist of a fenestrated endothelium, a fused basement membrane, and an epithelial layer. Its fenestrated capillary endothelium acts as a size barrier. It allows for the filtration of fluid, plasma solutes, and protein, but not red blood cells. Red blood cells are too large in diameter to fit through the smaller capillary fenestrations. The basement membrane is fused with heparan sulfate. Heparan sulfate is classically thought to act as a charge barrier for negatively charged molecules. Now, there's some conflicting evidence regarding where heparan sulfate is actually located in the filtration barrier, so the USMLE is unlikely to test you on this specific fact, but I want you to keep in mind that the basement membrane is fused and that negatively charged particles are prevented from being filtered due to the presence of heparan sulfate. Now, this charge barrier is lost in nephrotic syndrome. Do you remember how this syndrome presents? Correct. Nephrotic syndrome will show protein in the urine, specifically albumin, hypoproteinemia, because all that protein is being lost from the blood vessels, and generalized edema, again, because without the protein in the plasma oncotic pressure decreases. Fluid will then leave the vasculature and go into the interstitial space. The third glomerular barrier is the epithelial layer, consisting of podocyte foot processes. Podocytes are actually part of the lining of Bowman's space. They create a tight network of foot processes that help to filter protein and solutes from entering Bowman's space. Now on the test, you might see a question that describes an elderly patient with a 12-year history of diabetes. He hasn't seen his physician in 8 years and his creatinine level's 2.7. What do you think the diagnosis is? Well, this is likely a case of diabetic nephropathy. What screening test do you want to order to make sure diabetic nephropathy isn't progressing? Well, that's a urine microalbumin. Diabetic nephropathy at a cellular level occurs due to the disruption of the basement membrane, specifically the loss of the heparan sulfate molecules. Notice here in the image how proteins are being filtered through the damaged basement membrane. This change results in an increase in the filtration of negatively charged serum proteins, specifically albumin. Do you know what we might see on this patient's renal biopsy? Correct. Expansion of the mesangium with the formation of Kimmel-Steele-Wilson nodules. This is truly a classic finding for diabetic nephropathy. We'll cover all this again when we reach our renal pathology section. Now, despite the complexity of this filtration barrier, some solutes are still freely filtered. Can you name some of them? Amino acids, glucose, and electrolytes. Now this seems kind of odd because these are three things that the body would probably like to hold on to. And yes, the body does hold on to them, but the problem is that these solutes are the same size as the waste products which the kidney is trying to clear from the body. This is where reabsorption comes in. The kidney will eventually take back up all those important solutes the body needs as they travel through the nephron, while at the same time leaving behind waste products such as urea and creatinine. Now, let's move on to some equations that are important for renal physiology, specifically for determining renal function. Once you understand the concepts behind these equations, the equations themselves will become intuitive. First, we have renal clearance, a concept you need to know, especially for pharmacology. Clearance describes the volume of plasma in milliliters that is cleared of a certain substance X over time in minutes. Clearance is equal to UV over P, where U is the urine concentration of substance X, V is the urine flow rate, and P is the plasma concentration of the substance. Let's say that after infusing drug X into a patient's blood, we come back an hour later to find that the plasma concentration, in this case Px, is very high. What do you think this means? Well, this would mean that the clearance of the substance X is pretty low, which makes sense with the equation. If Px goes up, Cx will go down. Another way of thinking about this is that the plasma concentration of any substance that's cleared renally will be high when the kidneys aren't functioning as well as they should be. As we age, our kidneys' ability to clear drugs and waste products decreases. Now, how do you think this affects drug administration to elderly patients? Well, we generally want to give a lower dose of renally cleared drugs to elderly patients and to those with renal insufficiency. They'll naturally have a higher plasma concentration of whatever is being given to them simply due to the fact that their kidneys can't clear as much of the drug. On the other hand, what if we found that the urine concentration of substance X was very high an hour after the infusion? What do you think this would mean? Well, this would mean that the clearance of substance X is high. It's also intuitive that with higher urine flow rates, in this case V, the clearance of any substance will be higher because more urine can only be produced if more plasma is filtered through the glomerulus. Measuring the clearance of a substance and comparing it to the glomerular filtration rate can tell us how the nephron is processing that substance. Remember that the GFR is the amount of plasma filtered through the glomerulus per minute. If the clearance of a drug is less than the GFR, how do you think the nephron is processing that substance? Well, it's being reabsorbed. The kidneys are trying to hold on to some of that filtered substance. In contrast, what if the clearance is greater than the GFR? Well, this means the nephron is secreting some of the substance. Secretion happens downstream from the glomerulus, and it's the only way a substance can enter the filtrate once filtration has already occurred. If the clearance and the GFR are equal, that means no net reabsorption or net secretion is occurring. As I said previously, the GFR is the amount of plasma that is filtered through the glomerulus per minute. This can be measured using the inulin clearance. Sounds familiar. Where else did we discuss inulin? Correct, as a measure of the extracellular fluid volume. Inulin is freely filtered and neither reabsorbed nor secreted, so that's why it's used to measure the GFR. Now, in clinical practice, everyone uses the creatinine clearance because it's easier to measure. But keep in mind that it's a slight overestimate due to creatinine secretion via the tubules. GFR is used as a proxy to measure kidney function. It represents the balance between the Starling forces occurring in the glomerular capillaries. Now these forces are the hydrostatic pressure trying to push fluid out and the oncotic pressure trying to keep fluid in. In the bottom equation, Kf is the filtration coefficient, which is dependent upon the resistance to fluid flow through the filtration barrier. A higher Kf correlates with a higher GFR, and thus less resistance. Now what is something that could lower Kf? Asked another way, what could increase the resistance to fluid flow? Well, one example is damage or scarring to the glomerulus. Now this equation essentially deals with two variables, the oncotic pressure pulling fluids into a space and the hydrostatic pressure pushing fluids out of a space. Both the glomerular capillaries and Bowman space will have an oncotic and hydrostatic contribution. Now PGC is the hydrostatic pressure of the glomerular capillaries. Pi BS is the oncotic pressure of Bowman space. These two pressures will encourage plasma being filtered into Bowman space. Now in contrast, the hydrostatic pressure of the Bowman space and the oncotic pressure of the glomerular capillaries will inhibit plasma being filtered and thus decrease GFR. Now, don't worry about memorizing this equation. That's not something you need to do. Just be aware of the concepts of the hydrostatic and oncotic pressure. The test question will ask you, where is net fluid flow occurring? And they'll give you these values in the question stem. So there's no need to memorize the equation, just be aware of the concepts of where fluid's going to flow based on the hydrostatic or oncotic pressures. Let's do an example calculation. Calculate the GFR in milliliters per minute for a patient using the following values for inulin: for urine concentration, urine flow rate, and plasma concentration. Using the formula where GFR equals UV over P, we have our urine concentration, or 100 milligrams per deciliter, times our urine flow rate, which is 50 milliliters an hour, over our plasma concentration, 60 milligrams per deciliter. Now these two will cancel out, and we will get 83.3 milliliters per hour. Now because the question asked for milliliters per minute, we're going to divide this by 60, and this gives us 1.4 milliliters per minute.